Good morning. I'm Andy Shi, Chief Science Officer at Autism Speaks, an international not-for-profit dedicated to enhancing autism awareness, research, and services worldwide. It's a real pleasure to be with you today to share with you the latest update, as well as a review of the Caregiver Skill Training Program, a training package that was developed by WHO with support from Autism Speaks and implemented in over 30 countries worldwide over the past 5 years. So this is the community that we're trying to serve. As many of you know, less than 5% of the autism community actually live in high-income country, which are the country outlined here in orange. The vast majority of our family live in actually low and middle country, where the typical treatment gap is over 90%. What that means is that only 1 out of 10 individuals who need service and support on the autism spectrum are actually receiving the appropriate services in a timely fashion. So what we need is an equity-focused response to this global unmet challenge, that there's basically no capacity for implementing effective services in most settings in the community around the world. And what we need is a solution that's acceptable, feasible, effective, and sustainable that's part of a diagnostic intervention service for low resource setting. First, a little history about how we get to this point in developing the caregiver skill training package. I really started way back in 2007 when Autism Speak started to support Toddler Treatment Network, a research network really focused on developing effective intervention for toddlers. So these are mostly pre-diagnosed children who may have show signs of some risk, likelihood of being on the spectrum. And many of the parent-mediated intervention protocols and ideas really emerged from this collaboration or this research network. We were, of course, influenced by the passing World Autism Awareness Day resolution 2008, and quickly launched the Global Autism Public Health Initiative, Autism Speaks Signature Initiative, that's aimed to enhance public health response of communities worldwide to the autism and developmental disability related challenges. We issue our first call for a proposal, GAP RFA, for the Global Public Health Initiative in 2011. And that was closely followed by a second UN resolution tabled by the Republic of Bangladesh that addressed the social economic needs of the community. That set the groundwork for WHO consultation, the first in this decades-old history, focused on autism and developmental disability exclusively. That consultation recognized the need to develop community-based solution for our families. And those principles are really articulated in the World Health Assembly Resolution of 2014, as well as the first parent skill training consultation that involves stakeholders from over 20 countries around the world coming to Geneva and providing feedback and reaction to the idea of a caregiver skills training package. At the time, in 2015, the outcome from the RFA that we issued 2011 came to fruition, and Dr. T. Rahman, Vikram Patel, and Jonathan Green and colleagues published a seminal paper in JAMA Psychiatry, really demonstrating the first time how effective the task sharing strategy is in building capacity for evidence-based services in low resource setting, India and Pakistan. We're able to leverage this newfound knowledge and confidence to quickly move to finalizing a draft version of the CST, initiating pilots in over 18 countries by 2016, and starting a randomized control trial in several locations in 2017 and beyond. So, and ultimately, we have a really global movement of numerous sites conducting pilots and adaptations studies, as well as a randomized control trial that really demonstrate the efficacy and effectiveness of this package in the community setting. So Autism Speaks contribution to this whole effort is both technical and financial. On technical end of things, we provided marketing, which is a nice way of saying that we pitch this opportunity to country governments, often at ministerial level, but also with large NGOs and other foundations. We provide content expertise in terms of development of the package, and our director of inclusion and clinical services, Pam Dixon, is really the main technical lead for training globally at this point for the package. And of course, we facilitate and contribute to research collaboration in both the implementation, the pilot implementation, as well as the randomized control trials. In addition, we provide financial support for staff at WHO as well as UNICEF. We facilitate local ownership, meaning that we help identify in-country resources and both financial as well as human resources to support the initiative. And we seed and leverage research funding. So in some cases, we provide initial funding to generate data for further development. So the caregiver skill training program is really geared towards caregiver children ages 2 to 9 for development delays or disability, with a specific focus on caregivers of children with delays or impairment in the social communication domain. And the goal really is to increase caregiver skill to promote the children development and well-being through joint engagement and play and home routine, which we know have plenty of evidence support that these are critical points of intervention that can lead to generalized better outcome. The structure is really 9 group sessions with 3 home visits that help personalize the support for each family based on each family's priority, and generally engaging everything from engaging the children to understanding their mode of communication and behavior, and teaching skills that are important for everyday life, as well as promoting the well-being of caregivers and their problem-solving skills. So, for example, how do we get involved in children more often in daily activity? How we take turn, help children stay engaged, responding a child's attempt and effort to praise with praise and attention. These are all strategies that have strong evidence that shows that these promote social communication development, as well as positive behavior in children with development delay and disabilities. Now, what is unique about the CST is that it really has several key innovations. On your left is the Medical Research Council UK's implementation framework. And what it does is outlines the basic developmental process for intervention applied in the community setting. So you start usually on the very left with development, and you cycle through feasibility and piloting, evaluation, and implementation. However, the CST is different, is that we assume that the content, because it's really called from various evidence-based packages, the key active ingredients that we develop in the package, we know that it's most likely to work. So we start by thinking about implementation. Where do you want this package to live? Where do you want it to provide support for the community? And then work backwards from there, thinking about how do you really design something that could potentially be amenable to that kind of integration. So the implementation-driven perspective or strategy is really one of the innovation of this particular package. And as I mentioned earlier, the fact that it has adaptive package with kind of core active ingredients, right, that call from established interventions like Jasper and DTT and so on, PRT, is another major innovation of the package. And of course, we won't be successful. We don't have the right partners to enhance access and reach. And we also actively foster, support, and leverage local leadership and political will, either through top-down engagement or bottom-up support, as well as peer-to-peer networking and interactions. We leverage local human and financial resources to broaden ownership, enhance sustainability of the program over the long term. We provide target investment, as I mentioned earlier, in early stage research, such as pilot, generate key evidence, and leveraging opportunity going forward. And finally, we maximize implementation by diversifying dissemination opportunity through extensive community collaboration. So it's not uncommon for us to find ourselves collaborating with several agencies, organizations within the community to maximize dissemination implementation of this program. So the key relationship for the program then really is the UN agencies, such as the Permanent Mission of Qatar and Bangladesh, has been a longtime supporter of autism-related initiative, and of course our professional partners in World Health Organization and UNICEF. Many government ministries are also similarly supportive, the government ministries of Egypt, Malaysia, China, and Canada come to mind, have really providing both infrastructure and financial support for piloting and implementing the caregiver skill training program in their countries. Of course, we won't be where we are without our NGO partners, these are on the ground implementation partners. For example, in Serbia, we're able to benefit from a collaboration with the Institute of Mental Health, UMED, a community service provider in India, the Nobel Prize winning NGO in Humanity Inclusion in Nepal, International Medical Corps working primarily with Syrian refugees in Jordan, Hong Kong Jockey Club providing support for the social program, and a really parent organization called the ICO Project in Brazil had really done amazing things leveraging the development project from a medium-sized city, Curitiba in Brazil, to now is a Ministry of Health supported scaling our project in the whole country. In the US, of course, we also work with community organizations such as Charles B. Wang Community Health Center in New York City and the Color Autism Foundation in Detroit. More about that shortly. This is really more of an equity-focused approach, really trying to better support the underserved community within countries like the United States. Of course, most of our financial support come from international, national, state, and local and public and private funding agencies such as World Bank, USAID, Grand Challenge of Canada, and numerous private foundations. Now today, we have multiple sites globally, and here's the active sites here. What I want to draw your attention to is that a couple of things. One is that many of these sites now have multiple, many of the country now have multiple sites, and they're actually engaging scaling of activity. And many of them, especially the one with the crosses next to them, are really being supported by or mediated and facilitated by government, either the Ministry of Health or public health agencies. And the second point is that even those that are in planning phase or inactive, what we see is that the activities wax and wane over time when due to political changes or availability of resources or the development of international events and so on and so forth. But the key take-home point is that many countries now are fully on board with the program, are actively engaged in not only piloting the program, but actually scaling it so that it's accessible to the population countrywide. Here's a graphic picture of where we are. So we really have, I think, made a good initial effort trying to maximize the coverage worldwide for population. I want to turn the attention to the work in Huntington country, specifically in the U.S. As you know, many underserved community in Huntington countries, such as racial minority, rural community, really deal with this struggle with the similar challenges that are faced by communities in low and middle income country. Issue about access, about quality, capacity, and costs, and so on and so forth. So we saw the opportunity to implement CST in these communities as well to help enhance access to care for these families. And for example, in Detroit, we work largely with the African American community. In DC, Maryland, Virginia area, we're working primarily with the immigrant community of families from Ethiopia and Eritrea. In Pennsylvania, as well as South Carolina, these are mostly rural or underserved families. And I'm happy to share that these projects are all well underway, and is as we've seen other sites being well accepted by community stakeholders. I want to highlight two sites in particular. One is the Eastern Seal Midwest. This is a very rural part of America in the state called Missouri. It's largely rural farming areas. And we overcome some of the challenges related to distance and so on by integrating mobile health or e-health into the delivery using Zoom as a way to provide introduction to material and monitor progress and support the caregivers. And the second one is that we are working in New York City with Charles B. Wang Community Health Center, serving largely underserved immigrant families, with a focus on Asian Americans, and with private training and supervision. And they actually start training other care provider in the New York City area as well, so that amplifying effect disseminating this program through the community through peer-to-peer interaction is happening smoothly and well at this point. And of course, during the pandemic, they also had to pivot, so they help us develop some e-learning or e-health protocol to continue to support the community with the particular program. And when and maybe of interest is that a local congressional representative of the New York area recently introduced a bill in U.S. Congress that specifically support the piloting and implementation of the parent training program like the CST in 25 sites in the United States. We're looking forward to that as we make it through the government at this point. Now I want to also share some important outcomes. So, it's terrific that this program is being implemented worldwide at this point, but is it really working, right? So this is obviously a topic that's important for the team. And I'm happy to share that, we have today really collect multiple lines of evidence that really shows this value and impact in the community setting. From research update meeting we had in 2020, we were able to show that for both caregivers as well as child, there were distinct benefits, everything from increasing knowledge and confidence on quality of life to adaptive functioning of the child. And these are all been published. We see, how well the package is able to adapt in different settings, from rural Ethiopia to urban settings in Mumbai, India. And just as important, some of the randomized control trial outcomes are now starting to be published. The important one here is published recently by our colleague Erica Salomone and team in Italy, where they piloted the CST in a randomized control trial in the Italian National Health System. And what they found is there's a high level of feasibility with delivery by clinician, excellent acceptability to caregivers, and we see favorable effect even 3 months post intervention that include dialect fluency, the carer-child interaction seems to be much more fluid. There's increase in child nonverbal communication, caregivers skill support in the interaction, enhanced self-efficacy, part of caregiver, of course, stress reduction. So what's next? Well, on April 28th of this year, just last month, WHO Outspeak formally published the entire package. Now it's available. These are the packages available from WHO website. And so basically, after we wrote out this packaging now officially, freely accessible to the global community, we're planning regional, sub-regional orientation capacity building workshop in each of the WHO region in the coming year. And the idea is that we want to provide additional support, adaptation, implementation, and scaling up in different countries. We are already in the works on additional elements of the package. For example, with children with little or no spoken language, for children with motor impairment, caregiver well-being, as well as e-training for non-specialist facilitator. More to come on that. And we also start to expand target age group by extending the program both downward in age to children below age 3. And we're now starting the initiative to develop a similar level of support and services for teens and adolescents. I'm happy to share as part of the CST release, the e-learning version of the caregiver training program is actually now available through Open WHO website. What you have to do, just go there and sign up with your email, and you can gain access to it. Anyone can gain access to this important package of skills and information. It really is a self-directed e-learning for caregivers. It's based on the former CST program, skills and strategy. Totally, it's about 8 hours for a caregiver to go through it in a self-paced manner. It doesn't require high bandwidth, so it's really suitable for mobile devices as well. And we're currently, even though English version is available as of April, we're actively translating the package into Arabic, Chinese, French, Russian, and Spanish. So soon they'll be available in those languages as well. It can also be used for hybrid delivery of CST. So what we found is that many sites use the e-learning module for both for either homework or preparatory materials for the CST training session. And here's an example of what that may look like in the CST. So moving forward, at Autism Speaks, the technical center of the program had moved from public health now department to our support and services. And that just means that, we have a team now that really provide ongoing technical support for all implementation worldwide at Autism Speaks. And we're starting to expand our collaboration with other agencies, for example, UNICEF and other partners, HCDTF, to further disseminate the strategies as well as the content in the program in other communities around the world. And finally, we're leveraging the ECS to expand Autism Speaks' own digital health offering. For example, we have e-resources in screening and assessment, caregiver well-being, challenge behavior, as well as co-occurring conditions. So stay tuned, and we're going to try to make these available to our global population via a similar electronic platform. So I want to thank all of you for listening, for your attention. I want to close by thanking our global community for their contribution, their leadership, their patience, their support in making the EST a reality worldwide. Thank you very much.